Well, greetings and welcome everyone on July 10th for our first inaugural 24-25 academic year grand rounds. We are honored today to have with us Dr. Kurt Hegmann, the director of the Rocky Mountain Center for Occupational Environmental Health Multi-Institution Center of Occupational Health Studies. Kurt, as many of you know, if not most of you are familiar with, is one of the leading figures in occupational environmental medicine in the country, well known for his work in research, and particularly this subject here, cardiovascular diseases and relationships with common musculoskeletal disorders, as well as the chief editor-in-chief of the American College of Occupational Medicine Practice Guidelines, MD Guidelines, and many other publications and research and teaching awards throughout his long and distinguished career. We're planning to have additional grand rounds on a quarterly basis. So the next one will be in October, date to be determined, with Dr. Melissa Chen speaking to us about issues with opioid-related disorders and work-related injuries and illnesses. Kurt, without any further ado, if you don't mind, we can get started and be respectful of our audience's timing.
Thank you. Thank you so much, Eric. And I hope I can live up to the introduction. A little scary. It happens when you get older, I guess. Publications occur. This is basically a culmination, if you will, of a lot of years of work, starting back really in my training in the late 80s and 90s and looking at what was underpinning common musculoskeletal disorders. And so what I'm going to do is actually give you a lot of short snippets of research embedded in one talk. So if I don't make something clear, because I am giving this too short a snippet, just raise your hand and I'll work on clarifying that or comment online. So, and I take care of patients and we do consultations, and Eric mentioned the practice guidelines, teach and do grants. Mentors, these are some of my mentors over the years, we all change mentors as we go. We get different relationships and meet different people and learn from other people. So it's fun, I would say. The real credits for this research, and this is not the whole list, are all of these people. These are people who are involved in the data collection for most of the work, not all of the work, but most of the work I'll be talking about today, with teams at the University of Wisconsin-Milwaukee, Medical College of Wisconsin, and University of Utah. And there are additional people that I don't have on here because it just has never been a complete list. I'll have to talk to Dr. Thies about that. So what we're going to do is talk about these common injuries, and we'll talk about it from the standpoint of work context, but if you talk to people, if you talk to your relatives, it doesn't matter what they're doing for work, they're going to have a lot of these disorders. They're extremely common things that we're going to talk about. And mostly the epidemiology in these areas has been on the weak side. Not a lot of studies and not a lot of prospective cohorts and a lot of documentation of what's driving them. Whoops, went the wrong way. There we go. And if you want to look at, for example, what causes most of the disability, reported disability in the United States, it doesn't matter which source. So one of these is, a study. Another one's BRIFIS, which is Behavior Risk Factor Survey Study data. And what you see if you combine things like arthritis and orthopedic is you see it's half of the pool. So musculoskeletal is a massive quantity of the disability that we see in early retirements in the United States. The other biggest category is mental health. So between those two, if we knocked them out of the park, we'd have a lot more money and we wouldn't have such big deficits. So the first disorder, and I'm going to primarily emphasize 3 disorders with this talk, but we've got actually 4. We've got more than that to talk about, but these 4 I'm going to emphasize. The first one is going to be the rotator cuff, and the supraspinatus tendon is the focal point for the rotator cuff category of disorders, which is the muscle tendon unit at the top of this diagram. which is an area known for its relatively poor blood supply. This is something that has been written about in literature for over 100 years at this point in time, which is to say something. There's not a lot of things that have that kind of longevity in the literature base. And that's because it was looked at with anatomical studies, quantified for the first time in the early 60s by Rothman and Park, who looked at the blood supply to the supraspinatus tendon and found it was about 60% lower blood supply in older individuals compared with younger. And so everybody in this room is sitting there smugly saying, well, at least I'm not in the old group. But the problem with that is their definition of old and young classifies us all in this room as old. So sorry about that. And also along the way, they did necropsy studies, studies of dead people, and looked at issues of rotator cuff tears versus age. And this has been reproduced now with MRI studies subsequently. So it's really not in sync with the common, it's a sports-related injury, of course, because if it was a sports-related injury, you wouldn't see a graph that rockets up with age, right? So you'd see it plateau and stay there, because not all, but most people are not doing heavy-duty sports in the retirement years. We're supposed to be. And this is another one of these more recent studies looking at blood flow versus pathological state. In the right half of this slide, you can see the blood supply in normal versus impingement versus partial tear and full tear, that there's a difference. And so there's a consistent pattern here with respect to reduced blood supply and rotator cuff tears. Now that, mind you, is not the only theory. Especially in 1972, Charlie Neer, a pretty famous orthopedist, hypothesized that these were mainly tears based upon impingement, which is to say pinching of the tendon in the joint. Looking at these data, and what I'm going to cut to the chase with is I don't think we're going to support that as a primary theory anymore. The data are just too strong on the blood supply side, in my opinion. The epidemiological studies in this area have been, again, relatively sparse. This is like a typical one. I can't go through the entire literature, but one looking at relationships of tobacco and neck shoulder symptoms and elevated odds ratios. Again, mostly cross-sectional studies, so odds ratios, they're not longitudinal studies. They can't demonstrate temporality, but there are trends. There's patterns there. And if you look at one of the studies we did, this one's about 20 years ago, we looked at the risk of rotator cuff related surgery from body mass index, basically, and found a significant relationship. We did that study after we did some lab studies because the lab studies suggest that there is a relationship with position and your maximum capabilities. These were lab studies that we did in females. We did females because the question is designing work. You would design it for females because you'll design it for the overwhelming numbers of men, because the shoulder is pretty much the weakest of the major joints between the sexes. And the male strength is about 2.5 times roughly that of females on average. But anyway, one of the things about this study, though, in looking at the position and the maximum capabilities, is it doesn't line up with what, of course, people are told, which is overhead work and avoid overhead work. Well, these data actually say avoid work straight out in front of you, not overhead. And we also did those data after giving the person the weight in that position instead of having to lift it up, and it's the same pattern. Although from a design standpoint, the engineering side, you gain about 26% if you present the part or object up at a higher level, as opposed to having and requiring the worker to lift it into place. And we also analyzed the risk of, now this is incidence, so this is longitudinal data, the risk of right shoulder tendonitis case in cohort design by strain index category, okay? For the folks who are not aware of the strain index combines force, posture, duration of exertion. There's 6 variables. And it's designed for elbow south. So you shouldn't be using it on the shoulder. We use it on the shoulder. Why? Because there wasn't a good model. On the shoulder, that was simple. And because our data were suggesting force and posture and repetition were significant risks. So we thought, well, you know, it's going to at least give you a rough gauge. And sure enough, there was a relationship, as you can see. And if you're going to boil down 3 of these disorders and what the overall literature would say, you would see this kind of pattern. Now, you could add a few and subtract a few, depending on your view of the epidemiology. But this is pretty much what things look like, and there's some patterns there. Now, when we started our cohort study, that we'll talk about the data here in a moment, and we started enrolling people in the spring of 2003, some of these things were not on this list. And that's just the slow progress over time. Wish it was faster, but it was slow. So one day the data were cranked by Matt Thies and others, and results handed to me because I'm not a good biostatistician. And so we'll now get into our data from the prospective cohort study. So I need to tell you about what data we have and how they were measured. This is published and there's a number of references I have here, but it was published in a protocol paper. So we have questionnaire with 266 items, measured height, measured weight, because the men say they are taller and the women say they don't weigh as much. And the men do that too, but you know, there's a rough pattern there. And measured blood pressure, heart rate, wrist width and depth with caliper measurements, a lot of other measures. I'm just giving you some of them. We administered structured interviews by laptop, and Dr. Wood knows all about this because he was involved in these. But at this time, starting in 2003, you say today that this is routine. Well, in 2003, this was not routine at all. You know, and people were just barely starting to computerize things. We did that because of data capture. We knew it would be more accurate and we'd have a more complete data set. We also had a hand symptoms body diagram, which is 483 items altogether. We did 2 physical examinations, which are standardized. And the second one basically being more of a clinic-based approach of what are the positives and negatives and coming up with a case impression. So if you want to look at the study diagram, this would be it. It's a 9-year prospective study where we had a health outcomes team. We had a job exposure team to quantify the jobs factors. I'll talk about that in a little bit and give you a little bit more information on that. And then on the health side, we followed people monthly. We went into the work site. We actually knew the people. So we would, even when they went around the plant, and we knew when they were on funeral leave, and we knew it all because of doing the monthly follow-up. That's very different. There are studies that have done this sort of thing on 1-year basis, and all they end up with is recall of what happened over a past year, which, you know how accurate that is. On the job side, jobs were quantified at baseline, and then they were remeasured if they changed. So they would be reassessed on a quarterly basis. And nerve conduction studies. Everybody had nerve conduction studies done for carpal tunnel syndrome. So at baseline and every 6 months for anybody with any symptoms. So a lot of nerve studies were done. Rich Kendall here at the University of Utah led that effort, in case you're curious about who did that. So case definitions, rotator cuff tendinopathy, supraspinatus tendinopathy. We used a case definition. You have to basically come to agreement on what you're going to do with this sort of thing. You make them too specific and you cut too many people out and you would have diagnosed them anyway with that condition. We use a combination of glenohumeral pain, which is in this pain symptoms diagram, so basically shoulder joint pain, and then a positive empty can or supraspinatus test. Could you have done more? Sure you could have, but you would have narrowed the number of people and they would still been classified the same. For lateral epicondylalgia, lateral epicondylopathy, there's all kinds of terms all mean the same thing. How about tennis elbow? We looked at lateral elbow pain plus pain in one of 6 tender points. And we did that in part to describe the condition because it hadn't really been done very well on a systematic basis. And also because if you tear apart the literature, you see that people both clinically appear with pain in more than one of these locations. And that's also appears to be true in the sparse literature that does exist. And we medial epicondylopathy really looked at 2 tender points in the or painful points in the medial elbow. Case definition for carpal tunnel syndrome, we looked at, first of all, tingling and numbness or paresthesias in at least 2 median nerve digits plus an abnormal nerve conduction study read and interpreted by Jackie Wirch, a physiatrist at the Medical College of Wisconsin, as consistent with carpal tunnel syndrome. She overread all of them. Rich performed them here. And that's basically how that happened. They've now been standardized, by the way, more than they were at that point in time with accepted cut points. So that's one of the examples of things have changed a little. So if you go back in time, the first thoughts were that personal risk factors had relatively little impact. Repetition was the primary risk factor for these disorders. That's why they were oftentimes still called cumulative trauma and repetitive stress injuries and all sorts of terms that we tell our residents don't use those terms. Psychosocial factors were insignificant. Depression was occurring with back injury. And yet you look at the sparse literature base, and yet musculoskeletal disorders in aggregate are more than heart disease or cancer in terms of costs in the United States. So it's really amazing how off base we are. You know, we're like trying to extend lives by, 1 or 2 years, which is all great. And meanwhile, all these people are heading into disability. and we're not doing too much to prevent it. Well, we're going to go over a little bit of that current evidence. I need to give you 2 ergonomic tools, down and MD simple. We got engineers in the room. They can, run circles around me on this topic. The first one is TLV for HAL, or threshold limit value for hand activity level. 2 factors, force, repetition. That's basically it, force and repetition. This is probably now the most common tool used widely, in part because it's the simplest. A little bit more complex model, that strain index model, has these 6 variables. I mentioned it earlier. The more important thing is what drives it is the intensity of exertion or force measure. That was done based, and when it was designed, based on epidemiological data at that time in the late 80s and early 90s, showing that force seemed to be an important factor more than other things. Okay, so now study cohort, 17 manufacturing facilities for the most part, fair widely range of work. Now the goal here ultimately, the initial goal of the study was to look at whether job physical factors, work factors cause these musculoskeletal disorders and what can be done to prevent it, okay? How did that happen? That happened because the first use of the Congressional Review Act, this is for, history majors, the CRA was first used on the ergonomic standard in 2001, where some Democrats crossed over and they nixed an OSHA standard. That was the first year of the first Congressional Review Act that ever happened. But Congress at the time said, you guys got to do some prospective cohort studies to figure out what's causing these disorders. So that's how these studies got underway. We were one of the cohorts that got funded. Now, if you think about that, you need to have not everybody doing the same job, right? Because if everybody smokes, you don't find out if lung cancer is caused by smoking. Okay, there's no comparison. So what we did is we purposely tried to enroll 1/3 low job physical demand, 1/3 medium, and 1/3 high. Because then we have a spectrum, and we could even look at dose response relationships. So that's how these studies were constructed. And in the enrollment process, we estimate about 50% participation rate. It just kind of depended, some people like to participate, some don't. That's not as much of a study flaw in a cohort design. That's a much bigger flaw in a cross-sectional design. The other thing is we did not enroll jobs that were very difficult to measure because the engineers would have killed us, okay? too many job rotations, because every time you have job rotation, that's a whole nother set of analyses and videotapes to review and all that sort of stuff. So they didn't like that sort of stuff. So we avoided that. And then I'll show you. So this is an example of one of the high force, high demand jobs. This is red meat processing. And this is actually a facility here in Utah. This is a deboning operation. You're talking about high force to hold on to slippery objects in a cold temperature using a high percent duration of exertion and using a tool. Now, the workers make it look easy, okay? The workers always make things look easier than they are. This is a tough job. And so these are some of the analyses which were done, including just overall ratings, subjective ratings by the worker, by the analyst, and then measurements both in the plant and then taking the videos back to the lab to go over them back and forth to measure things like repetition rate, posture, percent duration of exertion, those sorts of things. About half of our jobs are rotated, and we ultimately use typical exposure because we didn't find much difference between peak exposure and typical exposure. This is a much easier job, an example, where you've got a more leisurely pace. There's a mini break, if you will, between exertions. The weight of the object is not, slippery and all those sorts of things going on. Here are some of the descriptive stats now from the population, average age of about roughly 40%. And it's predominantly female, so more weighted towards female because of the convenience sample, which means you enroll the workers. The men are, like it or not, cut to the chase, and it's politically incorrect. Men will do the maintenance tasks more than the women. The women are going to do the assembly tasks more than the men. The maintenance jobs are too hard to measure, so we're not going to put those in the study. So that's why you're going to have fewer men than women. That's the opposite of the back pain study, which I'm not going to present data from, where heavy lifting, naturally you're going to have more men doing that kind of work. Average body mass index was about 29, so right in the cut point between overweight and obese. And we had a fairly good dispersion of our job measures, either the TLV for HAL or the strain index. So we do have the power there to detect effects. So looking at rotator cuff tendinopathy, you enroll these people, you ask them at baseline, have you ever had, and also have you had in the past month? Well, in the past month, 26% had right glenohumeral pain. This study had so many examples where I went in with preconceptions and they blew up spectacularly, okay? This is one of them. I never would have guessed this kind of number, all right? I would have guessed 8%, 10%, there's just no substitute for getting real data. And then if you look at the case definition at the bottom, right, shoulder tendonitis, it's about 9% of the people met the case definition. That means they're not even eligible to become a new case in the duration of the study. They're already a case at baseline. And in looking at the risk for the development of right shoulder tendinopathy, body mass index was positive, high job risk ended up being positive as well. And we ultimately looked at it from the standpoint of Framingham risk scores. Framingham is one of the most common, if not the most common measure of what is your risk of developing a heart attack. So it includes a number of variables, of course. And after adjustments for those factors, including body mass index, which is not in the Framingham, job satisfaction, family problems, we found that as you go to the right, which is higher and higher risk of cardiovascular disease, you had more and more rotator cuff tendinopathy. So this is in alignment with, of course, that we've got a problem, right? That we've got potential prevention from the standpoint of risk factor modification. Now, we also looked at both lateral epicondylopathy or epicondylitis and medial. Lateral is tennis elbow, medial is golfer's elbow, if you want the lay terms, and everybody always says, I don't play tennis. Case definition we used was, again, the lateral elbow pain or medial, plus the pain on palpation. We also did measure resisted flexion, resisted extension. The reason we didn't include those in case definitions is because half of the cases would disappear right away. And we sat back and looked at it and said, they would have been diagnosed with this anyway. Okay, so if you think they really have a diagnosis, you don't cut the case out, because then you're not getting an accurate measure. So that's what we did. Baseline point prevalence of epicondylopathy was 17%. So again, number way beyond what I thought would be there. And then the incidence rate, we ended up looking at, ultimately, what is your lifetime cumulative prevalence? And we got 25%. And of course, that includes only the time of the study, which went for 9 years. So there would be more than that. This would be a minimum estimate. So, and translation into plain English, your chance of getting tennis elbow in a lifetime is at least 25%. Pretty high. At least I thought so. And looking then at odds ratios, what were the associated factors, age, female, gender, smoking, and diabetes, interestingly enough, was popping up there too. All of which, combined with what I told you in the past, in this lecture, said, gee, we should really look at the Framingham thing here too, even though nobody's talking about it in this diagnosis. And sure enough, we end up with the same pattern. And I should mention that when you get odds ratios of 5 and 6s over there, that's pretty high. Okay, just for comparison, what's your risk of heart attack from smoking? It's only about double. Cholesterol, only about double. All these things are only about doubles. So this also suggests that there probably is some interaction going on to get these kinds of magnitudes of risk, in my opinion. So now we're going to talk about the carpal tunnel syndrome results. And there we ended up with about 1/3 of the population having paresthesias or tingling and numbness in their hands. I was like, whoa. I mean, again, these numbers were just far beyond what I would have guessed, going into the study. Of course, I was younger in that day and age, so, but much more naive. Abnormal nerve studies, about 1/3 on the right hand, and you don't even have to analyze the data. For those who are the physician side, looking at the Tennells and Phelan's, you can right away see it isn't going to work very well. And that's actually the case. Because if you look at the positive predictive value of Phelan's, you'll get a, depending 5%, 10% prevalence rate, you're worse than a coin toss. Literally, you're better off with a coin toss. These tests actually work for negative predictive value, which nobody's taught to think that way, which is used in ruling out what do you do with a negative value. Everybody's taught to pay attention to the positives. And the same thing with Tennells, which should be no surprise because Tennells was actually designed, that's the tapping on the nerve, that was actually designed and described in World War I. And it was, Hoffmann was the German and Tennell was the Frenchman, so it's called Tennells because Tennell won the war, not the Germans. And they were tracking nerve regeneration from shrapnel wounds. So that's the history of the Hoffmann-Tennell maneuver. So no surprise it wouldn't work very well in CTS. Here's our data looking at relationship of body mass index and right carpal tunnel syndrome. I will comment, you can see other than the left bar, right, the underweight group, it's a perfect linear relationship, okay? The left bar is 6 underweight people who smoke like fiends. They are very interesting. So I don't know what's all going on with them, but they're just interesting. Probably would make, interesting people to talk to. The multivariate model looking at the strain index score and risk of carpal tunnel syndrome found, yes, that there is relationship with higher job physical demands for carpal tunnel syndrome. So we actually met the study goal. We did find a couple things, like partway down here. I mean, you can see obviously the body mass index is quite positive, looking at the hazard ratio and the p-value. But if you look at the specific distal upper extremity MSDs, there's a very interesting pattern here, which is to say the number, because remember, we were looking at all these different disorders on the same people. So we could look at how many of these disorders people had and developed. And you had 2 shoulders and 4 elbow things and, other things going on, and two wrists for carpal tunnel syndrome and other tendinopathies we were collecting. But anyway, your risk went up for carpal tunnel syndrome when you had more and more of these disorders. Okay, that again, to me, is suggesting there's some underlying pathophysiological basis going on here that may be beyond job factors. And depression may be a risk factor, actually. Again, this would be depression measured at baseline. This is not, I got the disorder, now I'm depressed. This is, no, you were depressed when you enrolled, then you developed a disorder. And our relationship between the job physical exposure and the hazard ratio for carpal tunnel syndrome, you can see, is also, again, rocketing up, interestingly, until you get to the highest group. And the highest group includes the job I showed you. And that job is so hard that it's a job that I couldn't do. Okay, I'm not built to do that. Most of these guys look like they are on the football team. Okay, I don't have that body. Okay. So one of the things we think is probably going on in that highest group are 2 things. One is selection into the job. Okay, is unique and unusual because it's so hard. And 2 is healthy worker survivor bias, meaning you've lost people who, like me, would have never survived in that job. And there we go again with cardiovascular disease risk and its relationship to carpal tunnel syndrome. These, again, are similar, and yes, there's relatively few people in these categories, which is one of the reasons why the numbers will bounce up and down a little bit, but you still see a trend going across the data of higher risk with higher cardiovascular risk scores. Before I go further, I'm going to pause for questions at this point, because next I'm going to look at prospective data combining these disorders, and if I've lost people at this point, we're in trouble. So questions at this point? Everything's clear. Okay, good. Okay. So then the next question that we addressed and analyzed and finally got published within the past year is the issue of, well, if somebody has high risk factors, they should be developing multiple disorders. And what is the relationship between the Framingham risk scores and the numbers of disorders that they develop over a period of time? Because remember, we have the ability to say people did or did not develop these disorders. And we knew if they quit, but for in 5 years or 4 years or whatever, we knew when they quit. So we had control over all that information. So that's where you hand the baton to the statisticians, and these are the data. This is a simple but busy slide. So first of all, let's look at the x-axis. The x-axis is, again, the Framingham risk score. And these are now relative risks for musculoskeletal disorders. Okay, so this is looking at your development of risk over time. And what we have now done is looked at whether you had one disorder, two disorders, three or four or more disorders. And if you start in the green bars, for example, you'd say, well, what's your risk of getting one disorder? Well, that risk, you know, in the high group there is roughly 4. Okay, so then you can say, well, okay, what is your risk of developing 2 disorders in that highest group? And now you have 6-fold risk. So you can look at this either one of 2 ways, either going left to right or up the bars within one category. Okay, and when you get to the highest level there of having 4 or more disorders, you see there is a tremendous relationship with cardiovascular disease risk. And let me put this in perspective. I earlier gave you the perspective of what is risk for a heart attack based on individual risk factors, right? We talk about tobacco, cholesterol, diabetes. These things are all 2 to 2.5, maybe 3 max, okay? And so that we're already above that in the highest groups, right, with the green bars, with one disorder. If you want to talk about really strong risks in epidemiological studies, you'll look at something like smoking and lung cancer, okay? Smoking and lung cancer, that risk is about in the area of 15 to 20-fold, okay? Smoking and heart attack, only about double. But smoking and lung cancer is 15 to 20-fold, okay? And here you've got numbers up here that are in that category. All right. So what we've now been able to look at with these data is show strength of association, dose response. We've been able to show temporality, that these things are measured before the development of disorder. Okay, we're ticking off one after the other of the boxes on the Austin Bradford Hill criteria for causation, which were published in the Royal Proceedings of Medicine in 1965, making the argument of what we should look at for the smoking argument. This does not obviate the issue that there are job design issues, right? Those are still there. But this is suggesting, in my mind, that we've got 2 avenues of preventing of these disorders, which we're not exactly talking about as a society. Yes, we talk about them in terms of job design. We sure do, okay? But we don't talk about the cardiovascular risks, and we don't talk about how we could be implementing programs, including in the workplace, to reduce the toll of the disability cases, which I mentioned at the beginning, which are half of the disability cases that we see. So this is the meat of the data. I'm going to pause in case people have questions about this.
Can you remind us of the cardiovascular risk factor, the premium scores, in this population of workers? What does the curve look like in terms of the population from 0 to 2% to 15 or greater? Is it a bell-shaped distribution of these workers?
You mean where are the workers distributed?
Yeah.
The numbers? We've got a fair number in each of those categories. I don't know that we'd have to pull in the data. I don't remember the exact numbers. What we did have to do is thank you for asking that question. When you get to the 15 and up category, we had to collapse because the really high risks, we don't have that many of those people. Not surprisingly, right? Because they would develop all kinds of things that wouldn't be in the working age population. Yeah. And I think that the other answer to your question indirectly is every one of those things now is pretty stable rising risks, right? So that also tells you when we collapsed the data to produce this graph, we had pretty good numbers of eligible subjects. We collapsed them. I don't remember the numbers because it's long enough ago now. I don't remember. All right. Okay. Now I will mention that we do have a second cohort study that's been done on low back pain. This study was designed in the same manner. It began enrollments 1 year later. We followed people for up to 8 years. We added the state of Texas into these data, and each of these studies had a couple of plants in Illinois, not that many, not that many that they couldn't follow them from Wisconsin. But this study was looking at low, medium, and high job physical demands, mainly from a lifting standpoint. Okay, so again, as I mentioned earlier, it's more male predominant. And this study it had just been analyzed, and I do know from Matt that there is some relationship with cardiovascular disease risk, which is very interesting, because if you know anything about low back pain, you know that we don't know what causes low back pain. Vast majority of cases, we have no idea what causes it. In a study like this, I'm talking about like 98% of the cases. 2% maybe at most have radicular pain in a population, not a university clinic, a population of workers. Big difference. The sciatica gets attention and they run into the clinics. So you get population bias or spectrum bias. But anyway, so it'll be interesting to add those data into the discussions going forward. Yeah. So, you know, the power of these studies is we've got these cohort studies, and just the upper extremity study, we've published 31 peer-reviewed publications over the years on this, and we now have good estimates of population-based incidence and prevalences. The physical examination signs don't work very well. For those who've torn apart that literature, you already know what I'm telling you, but the literature in treatment is strong. I mean, you got randomized controlled trials and all sorts of stuff. Physical exams, those sorts of maneuvers, not very good literature. We did find that these types of musculoskeletal disorders are multifactorial. There are job physical factors. We're finding personal risk factors, and I didn't hit them very hard in this talk, but there are psychosocial risk factors, which are also panning out as positive and predictive of increased risk subsequently. Our studies are consistent in showing that force is the greatest occupational risk, which again emphasizes the issue that I will never succeed in getting this one stamped out, but the use of cumulative trauma and that sort of thing should really be thrown in the waste bucket, because it's just so misleading to patients. Because once you know it's force, now you can actually deal also in a clinic, also in the plant, also in safety with what can be done to reduce and mitigate risk. And the risk factors do differ somewhat by disorder, although cardiovascular disease risks are clearly strong risk factors. And, you know, so I say to myself, okay, one day when you wake up and you have a patient with these musculoskeletal disorders, shouldn't you, and I read me, provide evidence-based care and mention addressing tighter cardiovascular disease risk factor control? And I have to continuously remind myself, I find changing prior practice is extremely difficult. We as adults have to unlearn our programming and I don't know. Okay, you can laugh and say maybe it's just because Hegmann's in his 60s, but you know, I think this is a problem even, you know, 20 years ago. If it helps, then you can just say it's just because it's Hegmann. That's okay. I'm all right with that. Now I'm going to speculate just what this one slide, and I will note that the issue of small vessel disease, which may be what we're dealing with here, has also been associated with cognitive decline, renal disease, hearing loss, macular degeneration. So we're starting to tear apart this literature as well, because we're starting to wonder if we don't need to reincept the cohort and look for all these things to see if that isn't actually in there already as well. So that then brings up ChatGPT. So I put, do cardiovascular disease risks cause musculoskeletal disorders? I put this first in May 2023. It looked about at that time like it was 50% was usable and 50% was word salad. Okay. If you ever put anything specific in there, you probably know what I'm talking about, word salad. Then after we get our publication out, the answer in 2023 was 100% useless vanilla. Okay. I mean, it literally was completely useless. And today I put it in there again just for entertainment purposes, and you can see what's popping up. And it's a mixture. Yeah, it's a mixture of junk and word salad. And it's just amazing. So on a good note for any faculty who have to grade papers or something like that, just ask very specific questions. I think you'll be safe to figure out who's using this junk. But it'll eventually be very good because the generic stuff, it's actually pretty good right now. But the specific stuff, it's, nope. And so it's time for questions and speculation or pontification too.
Kurt, so the literature on the outcomes from wellness programs is pretty mixed in terms of any kind of cost savings associated with those for you know, if people are beginning to pick up on this for corporate-based wellness programs and how, you know, addressing those might have a more bottom line impact in terms of work-related injuries and illnesses or presenteeism, absenteeism, et cetera?
Great question. So we clearly have a problem in the past with people actually participating in programs. We probably have that problem here at the University of Utah. And I think though, you know, we're starting to figure out ways around that, you know, with incentives, with gamification, you know, the things that are being done now that weren't done years ago, because you are right. The literature based on health promotion, disease prevention programs from the 80s and 90s is it largely was not successful. But again, I think, you know, there are some data now suggesting some efficacy, and I think we're also, again, in a better position. Oh, I should mention, technology may help some of this too, you know, the Apple Watch stuff and all that, because there's a lot of people like playing those games, you know, with their bodies, you know, and it's like, well, you gamify something and they got the device on them, you may get somewhere, you know, with people you never would have been able to touch before. So I think there's a technology angle on answering that question as well. But that's a very important question because, as you know, if it doesn't save money, the corporate side is going to say, forget it, we're done. Rightfully so, you know, because you really shouldn't just keep on hammering away on something. You should totally change it or revamp it instead of just do the same thing. Be with giving up completely. Other questions? Anything else?
Let's ask a question. Correct me if I'm getting this wrong, but I remember from the most recent paper that one of the potential observations was, or the questions raised was, does the development of these musculoskeletal disorders, is that a potential harbinger for having heart attacks or cardiovascular disease? Can you talk about that a little bit? And is that like a warning sign that people should maybe be thinking about?
That is a really, really good question. It's one of the other reasons I mentioned one already for looking at reincepting those cohorts and seeing if that actually would pan out. Let me backtrack to heart attacks are large vessel, medium vessel disease. These impacts are small vessel disease. You'd think that they kind of go together, but until you prove something, well, you already know what my predictive ability was at the beginning of the study. I told you repeatedly I was wrong. So I think we have to actually measure that. But I very much am concerned. That would be also a good thing though, right? Because then you'd have a early warning signal going off. This person's on a trajectory for bad outcome. Any questions online, Baba? Okay, perfect. And if there are no further questions, I appreciate it. Thank you very much for attending.